So everyone take a good look at that. Okay. Is Dr. Hare here? Okay. Come on up, Dr. Hare. So first, Dr. Gary Smith gave a fantastic presentation, and I just wanted to point out that Alfred Taubman received one of our organization's Stem Cell Action Awards for his philanthropy in 2010. Just one of the great people that have contributed and helped the field. So thank you, Gary. So it's my distinct pleasure to introduce as our next speaker, Dr. Joshua Hare. I serve on a couple of committees at the Interdisciplinary Stem Cell Institute at the University of Miami Medical School, Miller School of Medicine. And of course, I graduated undergraduate in law school at the University of Miami, and I'm certainly proud, very proud of the work in the stem cell field that's going on there. I remember a few years ago, Dr. Hare, when he first came to the university and had a presentation, I was allowed to speak, and I pointed out that this nascent institute was going to be very, very important to the University of Miami. It has been a magnet of some tremendous gifts from philanthropists, including those that we're honoring at our Stem Cell Action Awards dinner on December 7th, tomorrow evening, Bernie Marcus and Don Sofer. Dr. Hare is doing some landmark work with MSCs, mesenchymal stem cells, to mend a broken heart. And he's going to share with you some of the important research that's going on right now at the University of Miami in South Florida. We're also very proud that the University of Miami ISCE is also a co-organizer of our event this year. Josh?
Good morning. It's really a great pleasure to be here with you. And Bernie, I want to thank you for putting on, first of all, a superb meeting again, and second of all, for allowing us to participate. It's also, I think, a very nice opportunity to follow with my presentation over the previous one by Dr. Smith, who very elegantly talked about the basic science of pluripotent stem cells, but he also made the case that clinical trials are the essential way to develop any therapeutic field. And indeed, that's what I'm going to talk to you about in the next few minutes. So our group at the University of Miami is very committed to basic science research. We have basic science laboratories, but we also have a clinical trial core. And our commitment has been to do clinical trials with the best available stem cells that are available for use in humans at this time, as regulated by the FDA, but also with the understanding that as the science evolves, there'll be new generations of stem cells that will come down the pike. These will be available for clinical testing, and we will have forged the way with the methodologies we've developed now. So this is actually a fortuitous time because literally in the last 2 weeks, we presented 2 new clinical trials, one for heart failure and one for aging frailty. And so I want to spend the majority of my time this morning showing you results from rigorously conducted clinical trials that are done under the auspices of the Food and Drug Administration and often funded by the National Institutes of Health. I think it's very important to lay the groundwork of why this is so important. These are statistics from the American Heart Association about the very exciting reduction in death from cardiovascular disease, coronary heart disease, and stroke over the last 10 years. So you could see there's been about a 14% reduction in total cardiovascular disease. That's the good news. The bad news, if this pointer works, is that that number, 224 deaths per 100,000 a heart attack, and that's what's depicted in this slide. The upper panel shows what the heart looks like right at the time of a heart attack. You can see the darker area on the top wall of the heart is the area of heart muscle that's died from a blocked coronary artery. And how that heals over time is in the bottom panel. It forms a scar, a very large scar in the heart that causes a process that we call in medicine remodeling. And what that does is it leads to an enlargement of the ventricle, and that is a substrate for congestive heart failure and sudden cardiac death. So we still have 224 deaths per 100,000 in the United States per year, and we're still spending about $300 billion a year to treat the consequences of heart attack, and that's after all of the advances in medicine. So there really is a need for regenerative therapy, and that's why I think there's so much enthusiasm about stem cells as a way to heal injuries that we presently don't know how to heal. Our group at the University of Miami, as many other groups around the country, have been very actively involved in attempting to do this over the last 10 years and have been doing it both in the basic science laboratory but also in clinical trials using largely a cell type that comes from the bone marrow called the mesenchymal stem cell. So this is how we manufacture mesenchymal stem cells. These are not pluripotent stem cells as described in the previous lecture, but these are an adult stem cell that have a limited repertoire of what they can turn into. But there's been a lot of enthusiasm in our group for using these cells in the hope that they would turn into heart muscle. Now, I'll tell you ahead of time that our research over the last 10 years have shown that they have a very limited ability to form new heart muscle cells themselves in the heart, but they do have a dramatic capacity to heal the heart, and I'll show you all of that data. So I think a big important part of clinical research is that you learn new things that you didn't anticipate when you went into the basic science. And that's still a good thing, because if we can cure some of these conditions, if I could you take it to the back slide, please. One slide back, please. It's still a good thing even if the cure wasn't the way it was intended. This is how we manufacture the mesenchymal stem cells in our GMP laboratory. We take a bone marrow aspirate from a young healthy donor. We take the mononuclear cells in the bone marrow and we can plate that out in a culture dish and take it through several passages. The nice thing about this is that we can quality control the production, and we can make sure that what we're giving back to patients is in essence a cellular drug, because we can very precisely quality control it. And you see in the bottom panel there, one of the things we do is measure the markers on the cell surface, in this case CD105. Once we have a healthy batch of cells that's very pure in CD105, it's very viable, we can give that back to patients as a drug. And this is what we've been able to accomplish. This is the data from an animal model, which we did for the FDA before they allowed us to do in humans. You could see on the left what the heart looks like with a healed myocardial infarction injury. It's got that thinned area on the top wall of the heart, the anterior wall. And in an example of an animal that received stem cell injections directly into that scarred tissue 3 months after the infarction occurred, so once the scar had already formed, you could see the dramatic difference. The scar is much, much smaller. It's much less in circumferential extent, and the overall shape of the heart is much, much better. So we've set about in the last 10 years to see if we can do this in humans. So what do the mesenchymal stem cells do in the injured heart? Well, they remove the scar tissue. That's a very good thing. They grow new blood vessels in that scarred area. That's an important thing. They reduce inflammation, and that's going to be very important in my talk. I'll show you how we've deployed that anti-inflammatory effect for many, many medical uses. And very importantly, they do stimulate new heart muscle cells to grow. They don't turn into heart muscle themselves, but what they do is they send signals to the body to grow new heart muscle. And we've proven that in the laboratory, and we've shown that that occurs in humans. So in essence, we are using these cells and have had very nice results at doing all of these 4 things in the human heart. Just 2 weeks ago at the American Heart Association, we announced the results of this study, a randomized comparison of allogeneic cells, those are cells from a donor, with autologous cells, a patient's own cells, in patients with non-ischemic dilated cardiomyopathy. Non-ischemic dilated cardiomyopathy is the other important cause of heart failure in the world. So what I talked about in the last few slides was people who have a heart attack and get a remodeled ventricle from a scar. These folks get heart failure because they either have a genetic disease or an overactivity of their inflammatory system, which causes the heart to fail. And we wanted to see if the same cells we used in the ischemic heart disease trials could work here. So the background is that non-ischemic cardiomyopathy is an incurable disease caused by genetic or inflammatory causes. Because of the properties that I described to you about mesenchymal stem cells, we wanted to test whether they were affected in this condition, and we randomized patients to the two cell types in advance of a trial that we'll now do with the best of these two cell types compared with a placebo. So this was a phase 1/2 randomized comparison of the two cells. We did this at the University of Miami. We enrolled 37 patients beginning in 2011, and we injected these cells directly into the heart muscle with a Noga catheter system. That's what the system looks like. And then you can use this catheter with this needle to inject the cells directly into the heart muscle at the desired area. As already alluded to at this session, it's very important that the first thing you do when you're developing a therapy like this is to test safety. We did that, and then we looked at a whole host of efficacy endpoints. How is the heart functioning? How are the patients feeling? What's their inflammatory situation? So the first thing was the safety. It turned out to be very safe, and there were no serious adverse events within 30 days. Every patient tolerated the procedure, was able to undergo it, and as I said, at 30 days, we're doing just fine. Now, things became very interesting as we followed patients out for 1 year, because we started to see that around between 6 and 12 months, that the patients getting the allogeneic therapy were having fewer side effects than the patients with autologous. So if you look at this side effect called MACE, which are multiple cardiac endpoints, only 20% of the patients with the allogeneic therapy had a MACE event, whereas almost 60% of the autologous patients did. If we looked at that further, we looked at any reason for being admitted to the hospital. It was reduced in the patients taking the allogeneic cells. More than 50% reduced. It was 28% versus 70%. So there are hints here that the allogeneic cells are working better because the patients are doing clinically better and requiring less hospitalization. Now let's turn to the heart function, and this is what I think everybody's interested in the field, particularly in cardiology. These hearts are very weak. Can we make them better with the cells? And we measure what's called the ejection fraction, which is the percentage of blood ejected in each beat by the heart. And lo and behold, the patients with the allogeneic cells had a very dramatic increase of 8 units, and it was not nearly as good, but still a nice improvement in the autologous. Now, what really struck us and really was very exciting to us is that 50% of the patients getting the allogeneic cells rose their ejection fractions to above 40%. 40% is actually the cutoff for the diagnosis of the disease. So about 50% of the patients treated by strict criteria no longer had the disease 1 year after the treatment. And here's a very dramatic example. You can see how enlarged this heart is and how poorly it's functioning. The ejection fraction is only 19%. This same patient, 1 year later, getting all other best conventional therapy, has a dramatic recovery. The ejection fraction is now 43%, and the heart has dramatically reduced in size. In essence, I don't want to overstate this, but this is as close to what we can consider a cure for this condition. This patient no longer has the criteria to meet the disease and is much, much better 12 months later. If we ask the question, how's the patient feeling? How are they doing? There are also several signs that the patients feel a lot better. Their symptoms of congestive heart failure are reduced, as evidenced by asking them questions on this questionnaire, as well as grading them in the New York Heart Association classification. These are very standard tests that are done in the field, and on both instances, the allogeneic patients are doing better than the autologous patients. How far can the patients walk? When you have heart failure, you can walk barely any distance, and we use 6-minute walk testing as a standard clinical tool and in research studies. Well, what we see here is that the patients can walk a lot farther with the allogeneic cells, and they can do so at a statistically significant greater degree than in patients with the autologous cells. Same holds true for their breathing function. So there are a number of measures that I'm showing you that the patients' hearts are getting better, their quality of life's improving, and their functional capacity is improving. Now, we've become very interested in how this happens, and we've measured a number of things. I told you that the stem cells stimulate the body to produce their own stem cells to a greater degree. And one such stem cell is called the endothelial precursor cell. This is the cell that lines our entire blood vessel tree. It's a critically important cell. With all cardiovascular disease and many other diseases, you lose these cells in your body. And what we showed in this study was that, in fact, the mesenchymal stem cells stimulated the patient's own body to produce a large number of endothelial precursor cells and bring the level of the endothelial precursor cells up to normal. Now, I've told you that the mesenchymal stem cells are anti-inflammatory. They have a number of interactions with the immune system. But one thing that we're most interested in heart failure is something called TNF-alpha. This is a cytokine in the bloodstream. The TNF-alpha drives the progression of heart failure. It's very elevated in patients with heart failure. And here we show that the allogeneic cells reduce the TNF-alpha levels by 70% and do so in a sustained fashion, and that this decrease is greater than the patients receiving the autologous. So by a number of measures, we see that the allogeneic stem cells improve the patient's condition and improve the biology of the patient. The endothelial precursor cell levels are back to normal, and their TNF-alpha levels have been reduced to 70%. So a very consistent story. So we were able to conclude in the study that the 30-day safety and tolerability was excellent in both groups. The allomesenchymal stem cells produced improvements in ejection fraction, 6-minute walk distance, Minnesota scores, reduced MACE events, and all-cause hospitalization. It appears that immunomodulation is critical. This is important in this disease, which is driven by inflammation, so the anti-inflammatory effects are very important. And what this kind of trial has allowed us to do, and I think this trial is a model for what should be done in the field, which is to first do smaller studies, show that the approach is safe, optimize the cell, which we've done. We've compared 2 versions of the mesenchymal stem cell, shown that one is better than the other, and this now paves the way for what we call pivotal trials, which is where we now compare in a larger population this cell to a placebo, and hopefully have these results bear out that the patients getting the cells do better than the patients not getting the cells. That is the pathway to getting approval from the Food and Drug Administration for the use of these cells in broader populations. Where are we going next with this field? Well, we're part of a network that the National Heart, Lung, and Blood Institute funds called the CCTRN network. And the CCTRN is very actively interested in seeing if we can enhance the efficacy of what we're doing. So we are now actively enrolling patients at 7 centers around the United States. I'll show you the 7 centers in a trial called the CONCERT-CHF trial. In this trial, we're testing the idea that mixing 2 different types of stem cells might enhance the efficacy of what I've already shown you. These are the 7 centers. There are two right here in Florida. There's one in Texas, Minneapolis, Louisville, Stanford, and Indiana. And it's directed by the National Heart, Lung, and Blood Institute, and the data coordinating center for this is at University of Texas. We're very proud at the University of Miami that our laboratory is manufacturing all of the cells for this, and I'm very proud that the cell lab folks are right here in the audience. Now, what's the idea between mixing 2 cell types? Why would mesenchymal stem cells mixed with another cell type, a cardiac stem cell, be better than the mesenchymal stem cell alone? Well, I already told you that the mesenchymal stem cells stimulate the heart to make new cardiac stem cells. So we tested the idea that if we mix them together, that we could perhaps enhance the efficacy. And this is an experimental model from a mouse heart that shows how this works. In this experiment, which was just published a few months ago, the cardiac stem cells are labeled by this green color, green fluorescence protein. And what we've done is taken a chunk of the mouse heart that has the green fluorescence protein labeling of the cardiac stem cells and placed it on a lawn of mesenchymal stem cells. And what you see is a massive proliferation of these cardiac stem cells. Not only do they proliferate in number, but they migrate out of this tissue into the surrounding milieu. So it's this kind of biology that we think is driving a greater efficacy. We've tested this in animals to show that it works in animals, and now we're going to go on and do the clinical trial. We are in the midst of the clinical trial. So if folks are interested in participating in a clinical trial, this would be the state-of-the-art clinical trial to participate in the United States today, and it's fully funded by the public source of the National Heart, Lung, and Blood Institute. So that's what I want to say about heart disease. I want to change the topic a little bit to a broader impact on health. Can these cells do more than heal an injured heart or heal an injured brain? Can they improve the overall health of the aging human being? And what happens as we age is we all develop a condition called frailty. And frailty is a biologically driven process that underlines aging, and we all get frail, but at different rates. So if you look at different populations of older individuals, some are more frail than others. And it turns out that the biology of frailty is very similar to the biology of heart failure, and therefore our group at the University of Miami has become very interested in using the mesenchymal stem cells to treat frailty. So aging frailty is a common geriatric syndrome. It affects 10 to 15% of individuals over the age of 65. Again, it's a chronic pro-inflammatory state, just like heart failure is. There's a loss of physiologic reserve. And the more frail you are, the more likely you are to have an adverse health outcome from another medical condition that affects you. This is why this is so important. This is the impact of the aging population in the United States of America. We estimate that in 2020, just a few years from now, we will exceed 50 million people who are greater than 65 years of age. And by 2050, that'll be almost 90 million people. We live in an aging society. So one of the first things we asked as we became interested in aging was, is there a problem with the stem cells? Do they lose their effect in older individuals? And we were able to look at that from our different clinical trials. We have studied about 300 patients in cardiac clinical trials now. So we did a simple experiment where we looked at the effects of our stem cells in people with heart failure if they were less than 60 or greater than older than 60. And it turned out that was the midpoint of the age of our trials. We had the same number of folks above and below the age of 60. And we were very pleased to see that the effect of the stem cells in the heart failure population was not lost in the older patient population. If anything, it was slightly greater. So this was one encouraging sign for us that this idea of using these cells to treat frailty had some merit. This is the prevalence of frailty in Japan. Japan is the country that has the greatest number of older individuals and therefore the greatest amount of frailty. I show these data because they're dramatic, but the truth of the matter is the United States is not far behind Japan in terms of the impact of this. So if we start to look above the age of 75, you can see there's a dramatic increase in frailty. And folks who are in this group, the 80 to 84, have a 20% rate of frailty. If you're greater than 85, you've got a 35% chance of being frail. So this is a major health problem. And again, because of the things I already told you about allogeneic cells, we thought it was very reasonable to do a clinical trial of administering these cells by intravenous infusion in patients with aging frailty. However, we did this very rigorously, as I've shown you before, doing randomized clinical trials. And in this case, the data I'm about to show you, we used a placebo control. So about 2 weeks ago also, we had a very busy week where we presented 2 results. I showed you the Poseidon DCM. We also announced the results of the Kratos trial, which is allogeneic mesenchymal stem cells for the treatment of older individuals with frailty. And the background of this trial is frailty is a syndrome of multi-system physiologic dysregulation. It is characterized by having at least 3 of these factors: weight loss, exhaustion, weakness, slowness, and decreased physical activity. There's an increased vulnerability to adverse health outcomes. There's absolutely no treatment for this. We have no medicine that the entire medical community is aware of that can have a positive effect in this condition, and therefore it was very reasonable, based on what I've told you, to use mesenchymal stem cells in this condition. So the hypothesis is that, first of all, we always start with safety. That's been mentioned a number of times. The hypothesis is that the mesenchymal stem cells are safe, but could also have efficacy in this population. The study endpoints were 1 month safety, as in the other study, as defined here, and then as in the previous study, we had a long list of efficacy variables. In this study, we randomized patients into 3 groups. We wanted to, first of all, identify the optimal dose. And so one group of patients got 100 million, another got 200 million, and the third group got a placebo. This was strictly double-blind, meaning that the doctors didn't know what the patients were getting and the patients didn't know what they were getting. So all of the patients were followed for 1 year, not knowing what they got until the end. And here is the list of endpoints. Again, they characterize a patient physical capacity, quality of life, lung function, and then the inflammatory biomarkers. So just to quickly take you through these results, the 6-minute walk distance is a very important measure of how people are doing. If you're old and tired and weak and you need support, how far you can walk is a very important measure of your quality of life. If you can walk an extra 100 meters, that makes the difference between being able to go out and conduct your activities of daily living or not. So we measured the 6-minute walk distance, and lo and behold, we found that folks in the study could walk more than 50 meters more. It was an average of about 70 meters 3 months after getting the cells, and that was sustained for 6 months. The 2 bars represent, on the left, the blue is 3 months and the green is 6 months. What was very interesting was that the effect was lost in the 200 million group. So 100 was preferentially better than 200, and the placebo group did not have an effect. But there was a statistically significant 70-meter increase in walk distance in the patients with the 100 million cells. Now, we looked at another way to index this, which there's a test you can do called the Short Physical Performance Battery, and we were very pleased to see that, like the 6-minute walk distance, this was statistically improved in the 100 million group, but not seen in the 200 or the placebo. When we looked at lung function, it was also improved in the 100, but not the 200. So I hope you're seeing the pattern here, that the endpoints are the same for the frail individuals as they are for heart failure. There's the same degree of improvement using similar endpoints. There's another, this is what's called a patient-reported outcome, where the patients, you give a questionnaire and the patients tell you how much physical activity they're capable of. You see that it's actually declining in the 200 group and the placebo group, but there's a trend towards increase. Certainly there's a reversal of the decline in the 100 million group. And finally, our old friend, the TNF-alpha, well, I should say our old enemy, because TNF-alpha is bad. It's bad in heart failure and it's bad in aging. It's not nearly as high in aging as in heart failure, but it's still elevated compared to normal people, perhaps 2 to 3 times elevated, whereas it's about 10 times elevated in heart failure. And again, you see a very nice statistically significant decline in the 100 million group, lost again in 200 and placebo. We're not entirely sure why the effect is lost at the higher dose, but it is something we've seen before in heart failure trials. In the very first heart failure trial we did a dose response, and again, it's lost at 200. This is a very important lesson because it shows that too much can be bad, and this is also another critical lesson in developing therapeutics. You have to know the correct dose. People who've been doing drug development for the last century know this. The first thing you do is find the right dose, and using cells as a drug is no different. We should not assume that the more you give, the better. You have to find the right dose in an early study, and then you go on to do your pivotal trials with the right dose, the right delivery, and the right time and the right patient. So just to summarize, this is the decline in frailty. It's progressive. You start with isolated functional decline, progressive functional decline, dependence, disability, incapacitation. We think that the early phase is where you could have an impact and reverse it with cell therapy. And here is the summary of what we showed in the CRADA study. There was a 44% improvement in the inflammation, a 41% improvement in the endothelial function. I didn't show you that data. Endurance is improved by about 20%, and you see the other parameters. So we are hoping, and our paradigm is that we can actually impact upon this reversible period of time in the frailty process. Bernie mentioned that we have a wonderful center at the University of Miami. It's called the Interdisciplinary Stem Cell Institute, and what we've been able to do, because we've had a clinical trial unit, is expand our sphere of activities into 20 different disease areas. As shown here in this busy chart, it lists all of the different disease areas and all of the different numbers of trials. And I'm happy to send this slide to you if you want more information and think you might fit into one of these trials or might want to refer a patient to us. But this shows what we've been able to do with limited cell availability, but very carefully doing biology, understanding the impact of the cells, and then very carefully doing a clinical trial in appropriate patients. Now, I'll just end on one note, something we're very proud and excited about. We focused on diseases of aging, heart failure, and aging frailty, but we've also recognized that cell therapy is useful to children and neonates. There's a terrible condition, a congenital heart condition called the hypoplastic left heart syndrome, where the child is actually born with a single ventricle. There's only a functioning right ventricle and a non-functioning left ventricle. A group of surgeons, very talented surgeons over the last 30 years, have figured out how to correct this over 3-staged operations, as shown here. So these children and families have to endure 3 major cardiac surgeries starting at 2 weeks of life, and only 50% of the children survive the 3 surgeries. And many of them go on to develop heart failure after the surgeries. And so we've been working with a partner at the University of Maryland, Dr. Sanjay Kushal, to see if we could add our stem cells into this mix as the 4th step in trying to make these patients better. And we've begun to enroll patients in a trial called the ELPIS trial at the University of Maryland. So you can see how cell therapy is useful for all human beings, from children to older age individuals. So just some summary comments on the CRADA trial, the aging trial. Intravenous infusion of mesenchymal stem cells is safe in older individuals with frailty. The 100 million group was better than the 200 and increased 6-minute walk distance, the short physical performance, battery score, the pulmonary function. Both groups had a favorable effect on inflammation, but taking all variables together, we believe that the 100 million dose is better, and we are planning to conduct a larger trial that looks more carefully around that dosing. So we conclude that allogeneic human mesenchymal stem cells are safe and well tolerated in older individuals with frailty, and larger pivotal clinical trials of mesenchymal stem cells for aging frailty are warranted. I want to end by thanking a very superb team of colleagues and trainees at the Miller School of Medicine. I want to particularly thank Aisha Khan, pictured here, who's the director of the cell laboratory, and with her team, also pictured here, has manufactured all of the products right at the university that I've talked about. And Darcy DiFetti is also here in the audience, who has served as the director of research for us, director of the clinical trial unit for the last 10 years. We have been very fortunate to be funded by several foundations, the Marcus Foundation, the Star Foundation, and the Sofer Family Foundation, and we'll be honoring some of these foundations tomorrow night. at the dinner. And also, I have to mention that this would not have been possible without the public support through the National Heart, Lung, and Blood Institute through several mechanisms, one being the Specialized Center for Cell-Based Therapy, and the other active program right now, the Cardiovascular Cell Therapy Research Network, that's conducting 3 or 4 different clinical trials. If it wasn't for the public support, we would not be able to get to the point where we could take advantage of the foundation support to accelerate the trials. So I believe we've made a lot of progress in this field. It's very exciting. I think there's some therapeutic potential here for the use of mesenchymal stem cells. I think that the new generation of cells, embryonic stem cells and iPS cells, will enter into clinical trials, but are probably about 10 years behind where we are now, because we haven't even started to define the safety profile of iPS or ESC cells in human populations. That work is just about to begin. So it's, I think, a very exciting time in regenerative medicine. I think if we talk about the hope versus hype paradigm, there is some real hope, and there is significant data that is out there, and data that is accumulating. And I think the way forward for this field is to continue to do the rigorous clinical trials that have the solid foundation in basic science. So I'll end there. I'll thank you all very much for your attention.